a lot in there, Alan. It seems only fair to let Maureen have a go at addressing a few of those questions before we open it up more broadly.
Yes, having another half hour would be good. I think there's an interesting story behind this, because this has been an issue that's bothered me for a long time. And I came to the UK 10 years ago, even longer, on a study tour. And I was absolutely going to get to the bottom of why things weren't working in systems that were basically modeled on the UK. And I went into the trusts, and I went to the hospitals, and I said, do your physicians show up? And they thought I was a little nuts. They thought this was such a ridiculous comment. And I said, but you can't fire them. And they said, well, yes, of course you can't fire them, but of course they show up. Because there are values here that have built the system. And I think that that's not the case in a lot of other countries, where the workers feel that they're not paid enough, and they're therefore they're out to get the system. And I think that creates another level of discomfort. And I think, Alan, you've hit on a lot of the key issues. How do we know? And we don't know, and that's why I think this indicators issue becomes important, because we have no way to know. And what do we, when we know something in one country and something else in another country, and can we actually say that one is doing better than the other? You know, there are a lot of studies. They're isolated. They're not repeated. They're data sets. They're surveys, and they're not repeated. So, and that's why I think it would be good to have some agreement on what kind of things we should be measuring that will go beyond something general to something specific that's linked to service delivery. And I think the question that you asked about targets is something that we do need. And I think some of the more successful programs have had targets within a health system, within a set of hospitals that are in a survey or in an evaluation or a piece of research. And I do think research is really important. I think we do it sort of randomly, and we get some very interesting results, but it's like the randomized controlled trials that are applied to some of these issues. They're really very context specific, and can we aggregate across countries to say anything? So I think that's sort of a big problem. Secondly, how do you prioritize? And I think that it's hard to say, because for a couple of reasons, a lot of which both Alison and Alan touched on, is there's a political economy in every country, and some things are easier to tackle than others because there is a space that's open. And I think a lot of what the World Bank does is try to find that space so that we can help countries to go sort of the next mile in a particular area and hope that you can spread that. Because you can't say, well, the real answer is getting primary health care set up properly and working right, and having some incentives in there, and having some supervision that shows that things are actually happening. In some places, you're never going to be able to do that because the physician who is in charge of primary care is not interested in what you or anybody else has to say, and he's going to continue doing it the way he's always done it. So, but maybe in surgical theaters, you can have some influence, and you can improve maternal mortality, and you can improve infection rates, and you can improve surgical success rates. So a lot of it is really being opportunistic, and because there are so many building blocks, starting to build where you can and where there's interest. On the third question, you just sort of opened a can of worms, because I think that there are so many things that you've touched on, that why is it the way it is? And I think a lot of it, of the way it is because we have no standards. We have no measurement of what's going on in various aspects of the system. We have no incentives for good performance. There are no rewards for good performance, and no one is ultimately accountable. And I know I'm coming back to what I said at the beginning, but I think fundamentally that's the case, because they've been set up in such a way that accountability is not clear. There is nobody who's going to get fired. There's no one, in some cases, can't be transferred. For example, in Zambia, for a long time, they couldn't reduce the number of staff, and there were all these retirees, and they couldn't figure out what was going on. Turns out they had to give them a severance payment for them to retire, and so they never retired. So they got a donor to come in to pay that retirement, and they reduced the number of health staff by something on the order of 15%. So, you know, there are some major minor things that can be tweaked, that can fix a lot of things, but I think that we have to understand what's going on in the system, and that's not what's there. And I just want to address two things that you said that are, I think, relevant. One is the capacity constraints issue. These issues go on in middle-income countries that have considerable capacity to do a lot better. The whole structure is just not working properly. They have managers in the country, they have accountants, they have good physicians, they have at least adequate nurses, and they have infrastructure, but it's not working. So I think I'm glad you brought that up, because I think that makes it brings the point home. And no one is managing the system. I think that's the answer, because they don't have the authority to do it. And I think that's where a lot of countries really end up faltering, because they can't get their hands around it. It's too complicated, and they don't realize the complexity of it, and they may not know what to do. But I think that management is not high on the priority list. So on that, thank you.
So the ultimate political economy challenge. Can I open it up for questions, reflections from the audience? I'm going to have to ask you to speak into a microphone, because this is being streamed on the internet. Liam, if you could. You say who you are, please.
I'm Bruce Mackay from HLSP. We run the DFID Health Resource Centre. Not a lot of talk about doctors. I think the reason for the second to last point you made, Maureen, that about accountability, is that doctors are extremely powerful. If they had been unretired municipal gardeners in Zambia, the government would have got rid of them. It was obviously in the interest of retired doctors that they shouldn't be retired, and so they didn't get retired. I mean, this is a very powerful interest group, not just in Zambia, but everywhere. And when it comes to the political economy, that I feel is the biggest, one of the really biggest things. We're dealing with doctors. That's what makes it different.
Okay, very good. Any others? Yeah, please.
Hi, I'm Yasmin Hardy, also from HLSP. I was interested in the point Alan made about higher level. Why are these systems the way they are? And I think one of the issues I'm interested in is the accountability of the next level up, because we can collect the data of at the health centre level, of managers, of doctors, of nurses, etc., etc. But if the system is, and the decision making is created at the level above them, making them accountable is not going to change the system as a whole. It needs to be one level up as well. So who's watching the people who are watching the centres, kind of thing. And the second point is, were there any problems within the projects that you looked at, like the one in Argentina, where changes were made in the health sector, for example, incentives or paying them at a higher salary, etc., which then created problems beyond the health sector? Because sometimes they will say you can't make changes within the health sector because it will affect the education sector, it will affect all of the other sectors, because it's made by the Ministry of Labour. So the decision making takes place outside of health.
Okay, very good. Is there another question? Yeah, you and then in the front.
Thanks. I'm Hugh Wemman-Smith. I research urbanisation. Somewhat related to the previous question, your units are countries, but the degree of urbanisation varies widely between countries. The problems of delivering health services in rural areas are different, mainly logistics, compared with urban areas. And not just that, your model of governance is a national one, as I hear it. Perhaps that's wrong. Is there scope for more devolvement, whether to states or cities or other lower level units, to try and get more of the responsibility placed at a local level? So that's my question. Thank you.
Very good. And then in the front, and then we'll give you a chance.
Hi, Leo Bryant from Marie Stopes International. I was interested in your passing comments that contracting seem to have come up with good health results, and also in the comparisons with the UK health system. The NHS, of course, has a very large role for contracting GP clinics, abortion services, care services for the mentally ill are all contracted. Whereas contracting in developing countries tends to be regarded as a bit of an experiment and something that happens on a very small scale, which is perhaps ironic if you consider that the reason why the UK does contract out is because it's cost effective and it doesn't feel it has the resources in order to provide all these services itself. So I suppose firstly that observation in itself I'd be interested in your response to, but secondly in measuring the impact of contracted services in developing countries, is there an opportunity not only to look at the health outcome, but in the development of management capacity within the Department of Health or local health authority? Because in that setup, the role of government is purely managerial, and so perhaps there's an opportunity for managerial skill building through these kinds of projects.
Very good. Why don't you take some of those and then...
Yeah, no, these are very interesting questions, and your point on physicians is absolutely spot on. I mean, they are terribly powerful, and that's why I said that you really can't do some things if you're blocked by the physicians. In Russia, we tried, for example, to dismantle the TB hospitals, and we were unsuccessful in convincing the Russian government to do it. And it wasn't necessarily everyone in government thought it was a bad idea, but there were powerful interests. And we see that in many countries. And it's interesting. I think in developed countries, you have hospitals, you have physicians, you have pharmaceutical companies, you have medical suppliers, you have some balance. In developing countries, the doctors that are the top of the pile. But if they're interested in reform, many things happen. So, I mean, the flip side is true as well. On accountability, the next level up. Well, my problem is I don't see accountability at any level. And I think that it's because we don't have metrics for assessing how people are doing. You tend to have either unions or just government guarantee of employment. You have a problem in trying to hold people accountable because the ultimate discipline is to fire someone, but they don't have anything intermediate, and no one's watching, and there is no metric. And so if you don't have any of those things, then it's very difficult at each and every level. But I would basically disagree with you. If you can get the clinical level to work, you've actually achieved something. And it may not be that the people above them are accountable, but if they can do it in a positive way, you can at least make part of the system work. And you do see things like that in countries where somebody is you have a powerful physician who says, okay, we're going to make this work. And it does because it within his purview, he's both inspired people and convinced people to move who wouldn't perform. So, I think that accountability is important because it brings all of these other things with it. On the urbanization, it's interesting because there have been a lot of studies on how to devolve healthcare, and it sort of hits a wall after a while. What we do see working really well is in large countries like China or Brazil, certainly the U.S. I mean, you have states who take responsibility and actually do a much better job than the federal government because they're closer. In some countries, they're devolving down to the local level, which they've done in both Indonesia and Brazil, and they've had to aggregate up again because healthcare involves hospital as well as clinics, and you have economies of scale in urban areas. So you see that more in large countries and in federal countries, and in smaller countries that are rural, you obviously don't see it. And a lot of things are being tried on an experimental basis in rural areas to get management down to the lower level, but it's much more difficult because you don't have the agglomerative effects that you have in urban areas. You don't have the skill sets. But so some of that is happening, but it's mostly in middle-income countries because India spends very little, and it's sort of focusing on health now, and it hasn't very much in the past. On the issue of contracting, the contracting is done in various ways. Technically, this Brazil experiment was a contract. And that's one model. Another model is in Central America, they asked the community, but they gave them support and money. They didn't just give them money. And there's a really nice study that was done by someone in the UK about 10 years ago in Uganda, where they put the communities in charge, gave them money, and then watched them for 2 months. The money disappeared, no one showed up for work, the oversight committee stole the money and the drugs, and it was a disaster. So if you don't have, they're not accountable to anyone, the thing falls apart. And the last thing, somebody asked about Argentina, and there were bonus payments to those physicians who were doing, who were treating those women and were part of the program, and their performance and their bonus was tied to how well they did in terms of getting the women in, and in all of these other very specific, both clinical criteria and attendance criteria for the women. And in other places, what they're looking at is patient satisfaction, which is, it's not the only thing you want to look at, but if patients aren't happy, they're not going to go back, and there's something wrong. But we don't look at that very often.
Very good. Let's go for another round. I mean, one question I wanted to pitch, which is not in any sense to question what is an incredibly thorough and actually very thought-provoking piece of work, but to go back to a point I think Alan made, which is, in a way, if we're working with environments in which governance across the piece is challenged, how much of what you're really hitting on here is, if you like, unique to health? I mean, we would be looking at rewards and incentive structures, merit-based recruitment or otherwise, levels of leakage, kind of in any service delivery sector. Now, some of the dimensions might be more complex in health, but you have procurement challenges around textbook delivery and education. I mean, teachers are less powerful than doctors, that's for sure, but there are a whole range of issues in other sectors. So I suppose in the sense, do we feel we've hit you've hit on something here that's distinctive to health? Is it the particular combination of these governance challenges that is associated with health? Or is this actually just kind of drilling down around a set of indicators that we would be normally using anyway and saying, well, they have particular manifestations in the health sector? Are there any other questions along one at the back over there and then one in the front over here?
Yeah.
That's on, should be on.
It should be on. I think we all agree that there's a sort of political economy aspect to this, and that all these problems aren't something the health sector alone can fix. And so I was wondering whether, that certainly seems to be the truth in policy analysis. The big changes in policy development in health have always been where there are sort of external factors like really big dramatic crisis, a big court case, some sort of disaster. And it's where the political, political parties are interested, and where the media are. It's those external factors that often change the way people do health. So that makes me wonder whether you couldn't do more in your indicators about looking at attitudes to health, how the political aspects of it, media monitoring, looking at people, not just about perceptions about corruption, but also about whether people feel they've got access to complaint mechanisms, whether those are prosecuted successfully, whether NGOs are sort of representing people who have been the victims of poor service delivery.
Okay, so the kind of pressures that come to bear on the system. In the front row.
I think mine sort of follows on from that. I was wondering if you could speak a little bit more to the role of community monitoring in exacting accountability from service providers and leading to or contributing to better service delivery. You said that the research or the evidence isn't particularly encouraging, but I was wondering is there more encouraging evidence related to specific approaches or particular countries? I'd be interested to hear. And a reflection on the question that you posed, Alan, in relation to prioritising. It seems to me if as you say, this whole role of sort of community-based monitoring is a mantra within DFID, and yet there's limited evidence, it may well be a good one to start with.
Did I say that?
Yeah, over here, Liam, thanks.
My name is Francis. I was interested in the notion that we are to introduce more indicators in a country that is already constrained by resources. And when I hear about indicators, particularly for a health system that has, you probably want to collect data at the lowest level and probably one particular health facility only has one person providing services. Are there any suggestions within your research in terms of how that data can be collected in such an environment? Then a different question relates to upward accountability. In Kenya, there was an interest towards having performance management contracts signed by heads of government at permanent secretary level and below, and probably would maybe want a comment from anybody around who knows whether that has been successful or not, and I think it was being applied in other countries as well.
Very good. Thank you. What did you?
Yeah, let me take some of these.
Yeah.
Can I just take some?
Take
of these?
those, and we'll come back to you.
I'm not answering fully, and I feel okay, Alison. On your issue on the governance across the country, you're right. I don't think that it's unique to health. It's more complicated in health, and health is more out of control. Quite frankly, I think it's the fact that in education, some people are going to school. You have a higher education system that's working, but the fact that you don't have this in middle-income countries, I think, is actually even more disturbing that it's not working in low-income countries. Not that it shouldn't and it couldn't, but just that we're seeing this in health in a very broadly across a lot of different kinds of countries. And there's indicators we would use anyway. I don't think we have very many indicators that I talked about that we would use very much because we're not using them. And I keep going back to the indicators thing. I take your point about you've already got too many indicators and too many things being collected. But I think you can piggyback on some of those, and some of these are just basic management tools that should be introduced as a way in any country to sort of know what's going on. You're spending money and you have no idea where it's going or if it's going, or if the people that you're spending 80% of your budget on aren't showing up for work. So, I mean, there's got to be something in here that helps those managers and those people who are responsible to do something about it. And it's that we're trying to get at. It's not that it's data for data's sake. It's that you have a black box that's called healthcare, and we don't know what's going on. And I think that what it's trying to do, and Alan mentioned it, is sort of peel away some of the layers so that you can manage it better, and you know where the money is going, and you know that it's being spent properly. So I think it's a very important point. And on your point about Kenya, I don't know, but they did this in a state in Brazil. They called it shock management, and they have contracts, and they monitor every single month, and services have improved. But you're talking about a middle-income country and a governor who wants to be president, so it's worked really well. So on the political economy issues, the Ministry of Health in Argentina did it on a bonus basis and got a waiver from the Ministry of Labor. So it didn't go into the civil service; it was something separate. They did the same thing in the Philippines. They basically did it on experimental basis, and then they've just kept it on over time. In Brazil, they've gotten some waivers, but because they've done it on an experimental basis. But now the raging debate is, should we have all of our hospitals run this way? And needless to say, there are a lot of people who don't want it, and then there are a lot of people who are at their wits' end and think that this might be the answer. So I think that there are ways to get around it. The other thing is that you can always take one sector and say, well, we're going to experiment and do something new, and maybe that will illuminate for the civil service, and that can be in any sector. So I don't say that health should do that, but I think there are ways to mitigate the rigidity of what you find. And the NGOs have played some interesting roles. And there are a lot in Latin America, for example, there are a lot of NGOs that have gotten into setting standards and sort of providing oversight. And that's been quite useful because they have, for example, in Colombia, they had a list of what hospitals should be paying for materials and for drugs. And they had this list, and the government sent it out, and all of a sudden the prices dropped. And these guys stopped being listened to, and the prices went up again. So there is something to having that role. And in some of the contracting out that's done in Central America, it's done specifically to NGOs but they're overseen by the communities. And in that sense, the community oversight has worked, but it's for a very specific activity that is also linked to what the national government is doing. And as to these indicators on attitude, I think that's actually true. I think you could get a lot about complaints. And some places you'll go to hospitals in many countries and they have a complaint. And sometimes the director pays attention. Sometimes they don't have it, and sometimes they don't pay attention. But I think it's true. I think it's a really good way to get a sense of what's going on. And a lot of doctors who run hospitals will often say, we use that. Or the nurses in the clinic say, when they complain, we know. As to the justice system, it doesn't work very well for medical complaints. And they don't get very many, most countries don't get very many complaints, and they're not very well adjudicated, and it takes a long time. And so I don't think that's, even in middle-income countries, that doesn't work very well yet. I'm sure I could be corrected in a few of the more advanced countries, but in general, that doesn't work. And on the community monitoring for health, yes, I do think it's a good research topic. I think we need to know more about how it could work. The people who are doing the monitoring have to be accountable to someone. If they're not elected locally, what is their incentive to make sure it works? I think that's one of the problems. And we've been having this issue in the bank. There's a big debate about, how well can the community actually hold the leaders in the community or the service providers accountable. In education, what they've done is they've given parents budget capacity and oversight of teachers, and that's worked really well. It's very hard to give a community control over a physician. I mean, this goes back to the physician issue. So I think that's part of why it's been so hard in health. But it's not that it doesn't work, it's just that we haven't figured out how to make it work and what kind of incentives and sort of frameworks we need to make it all fit together and function.
Very good, thank you. We take one last round of comments. You were first, then Bruce, and then Lenny.
Yeah, Maureen, question to you. Zurab Kaviridze, International Medical Corps UK. Question to the table in your presentation where you showed 12 subcontracted hospitals and 12 public hospitals. And as I understand from the tables, the most effective model was subcontracting. However, you also mentioned that one of the important indicators, such as patient satisfaction, sometimes is overlooked. So have you looked at patient satisfaction in this example? And the second one is, have you noticed any cherry picking from subcontracting hospitals? And the second question is to the whole panel maybe. Do you think that firing a doctor is an ultimate discipline measure? Because the medical profession is very particular in doctors' relationship with their mentors and with the peers. So do you think by firing, you sort of punish a doctor ultimately? Maybe there are other measures that will have more power in some respects, such as making it more widely known among doctors that someone was doing something wrong. Some other measures that will have more peer pressure on people, on doctors.
Okay, very good.
Thank you.
Bruce again, and then Lenny on the other side.
Your slides did focus and credit at the top saying public healthcare delivery. Your title slide says healthcare delivery. And the big elephant in the room is, first of all, a very large private market in health. In India, 85%. Secondly, dual practice. Okay. So that actually the publicly employed doctor and nurse, and in fact just about anybody with any sort of job in a hospital or a clinic can go home at lunchtime and practice, earn money in the afternoon. Yeah. And thirdly, that health is a consumption good. Consumers want to buy it. Yeah. They'll take it for free if it's available. But if it's not for free, they'll pay for it. So you're dealing with a product, well, with a service, I suppose, for which there's considerable consumer demand. And you haven't mentioned that at all, by either the sort of structural issue around public and private splits, but also the nature of the good, actually.
Okay, very good. Final question, Lenny on the other side.
Thank you. Lenny Wild from ODI.
I've recently been involved in some work looking at aid and accountability to the health sector in Uganda. And I just thought I'd share a couple of reflections, and it'd be helpful to have your thoughts on some of the issues that we found. The first was that clearly there's big issues around the fragmentation and proliferation of donors in health, and that itself skews some of the incentives and accountability relationships, including around health service delivery, both where donors are providing project aid directly to districts or community levels, but also in terms of how they relate to ministries of health and government systems for health. And we definitely have found some big challenges there. So I would want to, it'd be helpful to hear a bit about how the indicators you're interested in are kind of factoring that in. Secondly, we found a lot of evidence of this kind of community level monitoring, but that wasn't being really fed up to top levels of government. Doesn't really have that influence in terms of accountability. And there was a sense that perhaps there's a bit more activism from some parliamentarians. And I'd be interested to hear if you've found any evidence of that from the work that you've been doing as a kind of intermediary role. And then thirdly, I think with a lot of the questions this evening have been about this tension between wanting to provide evidence and data, wanting to have indicators, but wanting to recognise the importance of context. And I wonder if there are any examples that you found which perhaps move away from cross-country comparisons, but really try to build on that, building the country picture about accountability in health. I mean, for example, in Uganda, the Ministry of Finance has developed a budget monitoring and accountability unit, which is actually going out into districts to try and identify whether the commitments that have been made by donors and government are being delivered on the ground, picking up on that challenge between what's on paper and what's happening in practice. And I think maybe that's potentially the way to go in terms of mapping out the governance and accountability realities, is trying to build from that very country specific approach.
Very good. Okay.
Okay,
Last stretch.
good question. Good questions. Okay, on the 12 contracted hospitals and publics, yes, they asked about patient satisfaction, but they have a long list of indicators, and they were all very positive for the hospitals. And this was very careful research that was done. So I think everybody feels that the evidence is pretty overwhelming, that they perform much better and at a much lower cost. On the cherry picking of hospitals, they couldn't cherry pick because they have a catchment area. They're all very poor areas in peripheral São Paulo, where a lot of the internal immigrants come, build houses, move up from shacks into other houses. So that's the catchment area, and that was the catchment area of the comparison hospitals. And as to the MDs, I don't think that firing is the ultimate requirement. I think they need to be disciplined, and there are various ways to go about it. There have been some studies that have compared the performance of clinical performance of physicians who are government physicians and for NGOs in Africa. And they have compared them and controlled for their education. And where the physician could be fired, they worked longer hours and they were they provided higher quality care. And what they did was they used pretend patients, right? And so they were more thorough, and they were consistent over the patients. So, I mean, it's not definitive, but it's the kind of thing that I think provides some clue that that's maybe something we should be looking for. But I'm not suggesting that the only way you deal with physicians is by firing them. I think that's a last resort. And I think there are other things you can do. Most countries don't try to do them. So on the nature of healthcare, yeah, I could have talked about it. It's a really difficult good. It's the kind of thing where most macroeconomists deal with a lot of issues in the World Bank because they have an overarching view of a country. And when it comes to health, they get very confused because their first reaction is, well, we should have the private sector do it. We're like, no, doesn't work very well that way. And they don't understand the dynamic of what's going on. And I think it's indicative of, because it behaves differently, because there's such high demand, and the people making the decision are not the patients, it's the physician that makes the decision for them. So it makes it all the more difficult and all the more important to have some oversight so that things don't go astray. And I didn't talk about that, but yes, I think and when people are sick, they're willing to pay absolutely anything. Mm-hmm. And we see that in a lot of countries where people go into debt to pay for health care that is very substandard. We have good evidence from China, from the U.S., from countries from Georgia. I mean, there are a lot of countries where they've done this, and it's a big deal. And yes, people are very willing to pay, which is why you have so much under the table payment, and why it's hard to break that, because people are willing to pay, and they figure they'll either get to the front of the queue or they'll get better care. Or what we found in Poland was they said, well, if I get sicker, or if I, am going to need something, I had better have this guy on retainer. And a lot of people do that. So it's a very complicated, and it's a little shady because it's illegal. And that's, I think, that's rather problematic. And as to the dual practice, it is pretty much universal, and countries that have tried to stop it have not been very successful. So I don't know what the answer to that is, but again, this goes back to the issue about we need some more research. I mean, none of these are definitive of any of the things that I'm saying, but that's some place where I don't think we know. On Uganda, geez. I have to end with this. This is tough. The fragmentation of donors is something that we've seen a lot of. We've seen countries complain about it. I just recently talked to 2 ODI fellows. Yeah. They were really impressive. You should be very pleased with the people you pick. And they just basically said they couldn't keep, the government couldn't put the accounts together because the donors kept going directly to communities. And so they didn't have any sense of what kind of foreign exchange was coming in, because they were changing it on the market and then paying for this, and the government didn't even know about it. I think that's a problem. This is a sovereign country, but that's my own personal view. That's not any official view of any kind. But I think that when that happens, no one can be accountable. It's really the donor that's accountable. I mean, they have to play a role. But I think it's very problematic, because it's very confusing to try to set up a public system with different levels when you have somebody coming in from the side with money and expertise and sort of undermining it, which is unfortunate. I don't think that that's the ideal way to go about things. On the community monitoring, yes, parliamentarians actually in some countries have gotten rather active on this and wanted to do something about it. So I think that you have to use all of government. I don't think it's just the executive branch, if you will. But I think also, this goes back to the cities and to the states and to the lower levels of government. They all have a role to play. It's just hard to separate some of it out sometimes. But I think that's part of what being a government ends up being about. And even if you're not providing services directly, because as you say, the private sector is very large in every country. It's just some countries we don't know how big it is. I remember I was in Sudan in the late 70s, and I said, well, what about the private sector? And they said, well, we have no private sector. I said, I don't believe that. And I said, let me do a survey. And they said, okay, fine. I ran out of money before I finished the catchment areas that I had identified. There was so much going on in the back rooms, with malaria slides. So I mean, I think there's a lot going on, and it's sometimes hard to keep a hold of it. And then on the indicators, actually, my own view is that these indicators are really useful in country. And I think getting comparable ones across countries is helpful. I mean, the doing business study, I don't know if you know what this is, but this is something the World Bank has done, and it's got lots of flaws. But what it does is it makes countries competitive. They go, oh, well, we're 120, we want to be 80 by next year. And they start changing their rules and making business more open, and it's been a very effective tool to get it on the agenda to talk about. Doesn't solve the problems, it's flawed, but it's been a very good sort of stimulus to talking about things that are important. And as to M&E, I think that the monitoring is something we don't do. We don't do enough of evaluation, and they're very different. But I think your point is really well taken, that if you have people going out to find out what's going on, you have some way of at least saying somebody is watching. They're not going to fire you, to go back to your issue, but they're there and they're going to ask you. And when we do surprise visits for some of the studies we've done on absenteeism, the second time we go back, more people are there. So, that kind of simple monitoring can sometimes really start changing a culture, because you don't have to do something drastic. I think my point was that you can't do anything drastic, so nobody tries to do anything, including monitoring. So I think trying to do these kinds of things, and this goes back to the communities. Can they do better? My guess is they can do better if they have authority and somebody's watching them or electing them. But if you don't have those incentives, I think you're not gonna have very much accountability, and if you don't have that, the whole structure and system isn't gonna work very well. So, thank you very much. These are
Thank
great
you.
questions.
Thank you very much indeed. I mean, I think that was terrifically stimulating discussion, some brilliant questions, as Maureen said. Thank you very much for a really stimulating presentation, Maureen. I think you've got us all thinking and so forth. And Alan, for your comments too. I mean, in a way, there are so many questions on the table, but I think we've at least been able to knock them around with some interesting debate. Thank you all very much for coming, and hopefully we'll see you again soon. Thanks.